All right. Excellent. So I'm going to get started. So welcome again for those who are just joining. Welcome to our webinar today, which is being hosted by GIN North America. Very pleased to welcome three speakers who are going to share their experiences around digitizing clinical guidelines. So my name is Kate Carroll. I am chair-elect of the GIN North America Steering Committee. And in my day-to-day, I am the Director of Clinical Guidelines and Population Health at the American College of Physicians. So I'm very pleased to be serving as the moderator for this session. Before we dive in, I will just go through a couple of highlights about GIN and GIN North America. So GIN North America has been a regional community of the Guidelines International Network since 2010 and was actually the first regional community of GIN. And so our aim is to provide a network for guideline developers, adapters, implementers, and others to form partnerships and discuss, regional guideline issues, really focusing on Canada, Mexico, and the United States. So to accomplish these aims, we organize webinar series like this, regional in-person events, and virtual coffee chats, and create other opportunities where we can all meet and share and chat and collaborate. So just for members, make sure that you do have an account. I want to encourage you to make sure that you have an account on GIN Connect, which is the networking platform for GIN members. And it's the best way to kind of stay on top of the latest news and offerings in the GIN community. If you're here live right now, you probably already are on GIN Connect because that's how you registered. But perhaps, if you're viewing this on the YouTube channel later and you haven't signed up, this is a good reminder. Speaking of that YouTube channel, so this webinar is going to be recorded and posted there. And if you haven't checked out GIN's channel, again, I would encourage you to do so. It's a really great resource where many of GIN's virtual offerings can be viewed. The GIN North America's other webinars that we've hosted, as well as webinars from other regional communities, highlights from the annual conferences and all that good stuff. So once I quit yapping, I will drop some links in the chat for both GIN Connect and to the GIN YouTube page. All right. And a reminder to save the date for GIN's 2026 annual conference, which is going to take place in Kuala Lumpur, Malaysia, from September 15th to the 18th. If it's a possibility for you, I can't recommend attending this conference enough. If you do have that opportunity, it's just a really wonderful experience to meet with colleagues from all over the world, hear about amazing work that others are doing. And I always find it kind of a comfort to hear that we're all experiencing pretty similar pain points as well and similar challenges. So up on GIN's website right now, there are key dates that are posted for the conference. So you can go check that out on the site, but just some highlights that abstract submission will open on December 1st and close on March 9th. LMIC grants will be accepted January 19th through February 16th. Housekeeping items before we get started. I just would ask that attendees please stay on mute to ensure that there's a nice, easy listening experience for other attendees. Also would request that you keep your videos off if you're not presenting. And then we will have a good amount of time for questions and discussion after the presentations. So you can use the Q&A option in your Zoom control bar. It will be next to the chat box and raise hand functions. To submit your questions, you can enter them throughout the presentation as they come up, and then we'll get to them at the end. Okay, so let's get to the good stuff. I'm really delighted to introduce you to our speakers today. All of our speakers are coming to us from the American Academy of Otolaryngology. Oh, guys, I practiced that one. Otolaryngology. Oh.
Otolaryngology. I'll do it for you.
Otolaryngology. I cannot tell you how many.
Or just say ENT. That's easier.
Here you go. I cannot tell you how many times I practiced that. Otolaryngology. Head and Neck Surgery Foundation. So Jacob Marszalek serves as the Director of Research and Quality, where he oversees initiatives that advance evidence translation into practice. That includes clinical practice guidelines, expert consensus statements, and research grants and Cochrane Scholar Program. In his current role, Jacob is leading a feasibility study on digitizing the Foundation's clinical practice guideline for Meniere's disease, which we will hear about today. Jocelyn Meyer serves as the director of the Region Clinical Data Registry. She has played a really pivotal role in advancing the Foundation's mission to improve patient care through data-driven quality initiatives. Jocelyn has extensive experience engaging with federal agencies, including Centers for Medicare and Medicaid Services, where she has contributed to numerous discussions and speaking engagements related to registry strategy, clinical quality measure development, and broader quality policy. And Dr. Chris Schultz has over 25 years of experience in otolaryngology research to include clinical practice guideline development and evidence-based outcomes research. As an investigator and methodological lead of the NIH-funded CHEER Practice-Based Research Network, she led dozens of studies across a nationwide practice-based research network with the goal of implementing evidence in practice. So with that, I will turn it over to our speakers.
Okay, let me go ahead and share my screen. Okay, can everyone see the main slide?
Yes. If you want to go, you can scroll forward to the agenda.
Okay.
So today we're going to cover the current landscape of CPGs, what are computable guidelines, digitizing the Ménière CPG, that's a feasibility study we conducted and presented at our annual meeting this past October, a few weeks ago. CPG implementation, and then harmonizing CPGs using our region clinical data registry. And I'll set the stage here by defining digitizing, which may not be foreign to this group, but definitely was foreign to our members. We're not talking about an app that, has the guideline in it that you can use. I mean, there are many companies that can do that. We're talking about taking the key action statements in our guidelines and translating them to definitions and elements that can be used to track and assess impact. We're also talking about digitizing methods of the guideline process using things like AI to expedite some of the processes within the guideline kind of continuum. We're a test case with Open Evidence. I know many of you have heard from them, and they're presenting, I think, at CMSS next week, but to see how we can start moving to living guidelines, so we can start expediting some of those steps in between a guideline that's already been published and an update using AI tools in a judicious way. You want to go to the next slide, Jacob? So the current landscape of CPGs, there is that stat that everyone gives, that 17-year gap in translating evidence into practice. I've been using that stat for 25 years, so that's how old it is. It's why I focus my career on practice-based research and implementation of evidence into actual daily practice and improve patient outcomes. Guideline development and implementation are in silos. I don't really like the word silos, but they're just not happening in parallel. There is a low adoption of clinical practice guidelines. We kind of know that, but we kind of don't. We just know it a little bit more qualitatively than quantitatively because we're not measuring it well. Multiple organizations are developing guidelines simultaneously, which can add to the chaos. And the low adoption that I just mentioned can be further complicated by the fact that many of our guidelines may have an equally, if not greater, importance to other specialties. So things like, for us, especially in otolaryngology, primary care, family practice, peds, emergency. So, there's a whole realm. We don't know the uptake in our own community, and then it's even harder when we go out to these other communities and disciplines. As well, it's an extensive development process. We follow a rigorous published process. It's multidisciplinary. It's can take anywhere from 12 to 18 months in our specialty to go from inception to publication. Our queue is very lengthy for what's in our queue as approved topics for guidelines. And that queue also includes it's lengthy for updates. So published guidelines that we want to update. So there's a critical need here to figure out something else. And so what we've seen, and Jacob's brought up this slide that's really depicting what I'm saying verbally, that we need implementation at the table. We need things to be happening in parallel. We need tech specs happening real time so that when we're developing the key action statements, we're also having someone at the table that says, like, can we measure? How can we measure? And sometimes the answer will be no, and the key action statement will still be necessary, such as with patient education. But we still need someone at the table at the same time, because maybe the key action statement would be written a little bit differently if we had implementation at the table. So I'm going to close there, and just you can kind of take a look at this graphic, and then we'll transition to Jacob for the next section.
All right. Thank you, Chris. So I'm going to go over what are computable CPGs. So Chris did give an outline earlier of what digitizing exactly is. There is a really great analogy into further understanding what computable CPGs consist of. And so you want to see computable guidelines are analogous to maps. There are four levels of progression going from the narrative, which is the traditional static guideline document, and with the goal of it being to have the guideline being executable and operationalized in decision support environments. And so I'm going to walk you through these four levels of developing computable guidelines. So first, we'll start off with the narrative. And as Chris noted earlier, the Academy has very rigorous standards in developing clinical practice guidelines, and we also follow the Institute of Medicine, now National Academy of Medicine's developing clinical practice guidelines. They've been developing guidelines since around 2006, and the manual is updated periodically. So here's a screenshot of the title of the manual and an example of what we'll walk you through of digitizing one of the key action statements from the Meniere's guidelines. Here's a screenshot of the example that we will show you throughout the level progression. And so you'll want to see this as a print map. So using atlases, the time before computers and CDs and GPSs were developed. So then the next level it then proceeds to is we then make it semi-structured. And so the objective of this is translating narrative elements into semi-structured logic. So this is akin to going from a paper-based map to a static digital map, where it's still static, but it's with the digital, you'll see an example of like CD-ROM maps. And the Academy's clinical practice guidelines do include a flow chart for clinicians to refer to as a visual when they're walking through seeing a patient who has symptoms of Meniere's disease. And you'll notice here I'm zooming in to the specific key action statement, that example that was shown in the previous level. And in this stage, we then take each key action statement and create a matrix table. And in this matrix table, it then shows the existing ICD-10 codes that are then tagged to that specific key action statement. And more will come along as we progress on how that the ICD-10 and codes connect with each other. And so then we get into the third level, being at a structured level. And so then we move in the progression of the static digital map into having it be calculable. So on the right, you'll see a screenshot of the map quest. Although the map quest is still static, it does give you that digital visual of the map, and it's based on the coding. So what we mean by computable recommendation is, I'm going to zoom in this specific example. You'll see a list of codes, of JSON codes that are related to this specific key action statement. And I'm going to zoom in into what we're trying to see, if whether the clinician has followed this recommendation against if clinicians should not routinely order vestibular functioning testing or electrocardiography. And so this is then coded, and then from this coding, it then produces a chart. And so what you see on the right-hand side is the number of patients that have been sent for vestibular testing, the diagnosis of the Meniere's disease, and then the performance rate. So the performance rate, the goal is to we want the percentage to be lower, so an inverse. That means the clinicians are following this key action statement that they should not routinely order vestibular functioning testing to establish the diagnosis of Meniere's disease. Then we get to the fourth level, and this is the ultimate goal of going from once a static map into what we use today, which is a GPS system. And so after going through the semi-structured, making the code structured, it then ultimately will go to the electronic health record, and it'll be based on the patient's context, much like how the GPS system is based on the driver's context. And then this, which we'll go over in a little bit, will then create a feedback loop of once when the guideline's created, it then becomes living by clinicians using a registry to report patient measured outcomes, which then feed into whether the guideline needs to be updated, as well as new research. And AI could play a role in this, given the vast development of AI. And so now we'll go walk through the example of what we've been working on, digitizing the Meniere's CPG. So the clinical practice guideline was published in 2020, and here's an overview of the proposed steps. So there are 3 steps. The first step, you develop a key processes table, then you develop a data elements table, and then concept maps. These are the deliverables for digitizing. So let's go through the first step in developing the key processes table. So on the left-hand side, it might be a little tiny, but this is that same flow chart that you saw previously of the Meniere's guideline. And so for CPGs, we already sort out the key action statements to a flow chart outlining how target patients should move through the clinical processes. So for example, you're seeing a patient with new episodic vertigo. You first start with a clinical history and a physical exam. You then move through the appropriate diagnostic steps, and eventually you have a patient newly diagnosed with Meniere's. So there's 3 parts to the chart that are then based on the sections of going through the clinical visit with the patient with Meniere's. So the first part you'll see is part A, and you'll see the starting point. You'll see that each key action statement is related to the diagnosis, the process. And then as you progress, you go down to level B, which when the patient is newly diagnosed with Meniere's disease, you go through acute treatment, and then persistent symptom management, you go to the next level of the flow chart. And so these steps then become data elements, and they define what data needs to be collected at each step to ensure it was completed as recommended. And so here we are back at the flow chart. So the CPG recommends assessing patients with suspected Meniere's for vertigo, tinnitus, and ear pressure. Therefore, a patient with Meniere's disease should have codes for vertigo, tinnitus, and ear pressure to support that the physical and patient history was performed. And so you'll see here a zoom in of the 2 processes of obtaining patient history and then assessing differential diagnoses. Similarly, the CPG recommends assessing for differential diagnoses, and that's in the second one. And then we go to the next part, deciding whether an audiogram was performed And so you'll see that zoomed into that specific key action statement. And these data element IDs are developed in-house. It's the way to code each of these processes. And then we move on to the key action statement 4, which offering MRI to patients with asymmetrical sensorineural hearing loss. And then the 5th key action statement, deciding whether to do not ordering vestibular function testing. And so this is just one part of the flow chart. And as I advance the slide, you'll see how this major section corresponds to the specific processes. And then that brings up to the next step, which is developing concept maps. So how do we actually assess who completed each of the processes as recommended by the CPG? Well, we connect our local codes to real-world data, which rely on standardized coding systems, such as the ICD-10, for example. For someone to be diagnosed with Meniere's, they would have to have a diagnostic code indicating vertigo, tinnitus, and ear pressure. For the steps recommending for or against procedures, we check if patients have CPT codes. For example, whether the vestibular functioning testing was not performed and whether electrocoagulography testing was not performed or the reason why it was done. There is versatility to adapt and map the data elements to any coding system needed, such as mapping pharmaceutical recommendations to RX norm codes. So down the road, our goal is to create a dashboard of CPG showing whether there is a change in practice based on the guideline. And then potentially you can incorporate artificial intelligence into the guideline development process. And as Chris explained earlier, open evidence for updating the CPGs. And now I'm going to turn it over to my colleague, Jocelyn, who will go over region and how it harmonizes the development of computable guidelines.
Thanks, Jacob. Awesome. So as part of the CPG digitization strategy, we are in the midst of taking those key action statements and transforming them into an interactive CPG assessment dashboard. So that will allow us to observe clinical adherence to the evidence-based recommendations in real time. So this approach will move beyond that static measurement to continuously evaluate the observations within their workflow. And this gives us insight into how guidelines are being applied within the day-to-day practice. Through this digitization, we are creating a natural bridge between clinical practice and quality measurement. So as a region registry, we do submit to a quality reporting. So this is going to make it an easy process to translate from this dashboard into a quality measurement. So we're looking forward to that. So meaning less manual abstraction, fewer reporting burdens, and more accurate reflection of the clinical performance, which I think all of our providers will definitely appreciate. So finally, digitization also improves the data consistency and analyzability across the sites by aligning the clinical documentation within standardized data elements. This creates a feedback loop between the EHR decision support and then region analytics, enhancing both patient care and then also as a research registry is going to improve our research potential as well. You see here, we do have a dashboard already created for a number of our quality measures that are based on our key action statements. And then if we go to the next slide, our vision is, Jacob, there you go. Our vision is to definitely look at all of the key action statements and look at the tracking over time. So for example, on the slide here today, we did apply this approach to a CPG that was published in 2019 that was looking at prescribing opioids for the pediatric tonsillectomy population. By looking at the prescribing patterns before and after CPG implementation, we observed a significant decrease in opioid use, demonstrating how this digitization can impact, and then moving forward, it can even have a greater impact. This framework also lets us review and refine those key action statements. So when we started diving into this, we saw there's a little bit of variability in adherence between practices. So this may suggest a need for clearer language. So it does give the CPG developers some feedback, a feedback loop, and additional context within the guideline itself. Through ongoing data review, we can validate successful recommendations and ensure they lead to measurable improvements over time. And equally important, digitization also helps us understand why some recommendations are being followed, whether it's due to workflow constraints, documentation gaps, or clinical disagreement. So all of this helps us refine both the guidelines and their implementation strategies, closing the loop between evidence and practice. So I think we can go to the next slide, and I think that opens it up for questions.
Great, thank you so much. That was such a nicely presented. I have to admit that I've heard about digitization of guidelines for many years, and this is the closest I've gotten to like really understanding what we're talking about. So you've already had success there. So again, I want to remind everyone that we have a question and answer box where you can drop your questions. You can also throw them in the chat if that's easier. And then I'd also encourage, the audience to share comments as well. Would be really curious to hear if other groups are out there, kind of delving into this work in a real way, kind of moving beyond concept to actually doing it, like our colleagues here today. So would love to hear kind of comments beyond just questions as well. So great. So we've got, so here's one question. How do we compare this with clinical practice guidelines on firework where CQL, clinical quality language, is being used along with FHIR for digitizing it? So
I'm kind of hoping Maria is still on the call.
Yeah.
Maria, would you like to chime in?
Sure. That's actually kind of the next step after this. So what this group did was just first of all, see if using some of the standards that are also part of the approach in CPG on FHIR was feasible. That's why it's a feasibility study based on data that they've collected in their registry. And so I don't know if you guys want to speak to what you're planning to do next, but the next step would be to then go forth and co-develop, if possible, the computable guidelines alongside the narrative guidelines. I think Chris kind of talked a little bit about being able to be more precise or work through challenging language maybe in the narrative for implementation and being able to actually kind of fix that before it's published, if it would mean the guideline is actually clearer and easier to follow. And for that matter, on the other end, even easier to measure. So the clinical quality language piece, for those that aren't as familiar with the standards, is kind of the logic. So that would be sort of your various algorithms that follow like the flow chart that Jacob showed, but put in almost like a statement that can be implemented in an electronic health record. So I don't know if you, Chris or Jacob or Jocelyn, want to say more.
I can speak to that. So we are a smaller association, but it still takes us time to change processes. I'll be completely honest, when we presented this at our annual meeting, we did have a very senior member that kind of thought that this is, walking on the moon type of stuff. So we do have to slow walk it a little bit with the comfort level, because we do have a very methodologically rigorous process. We're doing baby steps. We have an excellent team, came up with the suggestion of doing a computability rating of each key action statement, which is something that we're working on right now. So even if it's not implemented as part of the process right now, sitting at the table, that we are developing as the guideline process is happening, a computability rating that we can keep giving back to the panel to say, with these key action statements, you'd have a rating of, we don't know what it's going to look like yet, but if you have just standard coding like ICD-10s and CPGs, you could do this. If you need more upcoding like SNOMEDs and things like that, you could do this. If you needed AI modeling, like to look for clinical notes and whether patient education occurred, and if it was documented, it would look like this. And having that as part of the journal publication, our kind of pie in the sky that we don't think is too far away is that we publish a compendium with our guideline that gives the kind of coding for evaluating this in practice. So that's where we're headed, and we're a little bit slow walking it, but that's because we need to socialize it with our membership, and figure out the right way to have it part of the process. But we absolutely believe that folks that are implementing and informatics representation should be at the table at the panels as we develop them.
Great, thank you. All right, we've got lots of questions coming in, so that's great. Here was one. Thank you for your presentation. Could you share how long it took to abstract the data from the opioid guideline into the digitization framework? Also, what time frame do you anticipate for completing the Meniere's guideline?
So Jocelyn, do you want to cover opioid?
Yep, I'll take the first part. So within our registry, we've been accumulating data for since 2015. We have data going back to 2010, covering 13 million patients. So this has been an ongoing process to abstract all the data. I think probably this project, we worked with some of our research coordinators to develop the actual digitization, and then just applied that framework to our existing data set. So, I mean, it's taken a long time to get all the data, but this is just, as a registry, we connect to 40 different EHRs covering approximately 200 practices across the nation. So, the data is not we have the data to sort of apply this framework to any sort of project or digitization framework moving forward. And then I'll hand it back for the Meniere's.
I'll take the second part of the question with Meniere. So for the feasibility study, we did, so Jacob was highlighting, just for the sake of time on this presentation, just one key action statement, but we did do the full guideline. We just couldn't present it all here, and you'd all fall asleep probably, but we have the full guideline done. And the next step, again, kudos to the staff that we have, is we have a staff lead that is taking on a interrupted time series analysis of the Meniere's guideline using the data that we already pulled for that feasibility study. And so for those that aren't in the nerdy world, that we are, interrupted time series, ITS, is a within population study. So you have the same people in the beginning as the end. And in our case, the population is providers. And so because we have Regent, which is this very large data set, we can look at the time that the Meniere's guideline was published. We can match that. We can move forward to a couple different periods of time, keep the same exact provider group, and see if practices have changed. And so that will help us take what we've learned and put it out there to show how, if you do this type of work, you can track things over time. And ultimately, Jocelyn showed kind of some dashboard type representation in Regent. We'd like this to, our CPGs, to be part of our dashboards so that you can track the key action statements, and then you can use that to remedy and do quality improvement. And I just want to say, Kate, sorry, just as you can't say otolaryngology, like we can't say digitization. It's like the bane of our existence.
Well,
Like we need a new term.
I'm stumbling on both, so thank you everyone for your patience on that. I promise you, I was out there in my office practicing with my team members, and then I just watched it. So more questions. Congratulations, this is great work. I'm interested in the feedback loop. Do you have any experience of sharing implementation challenges with guideline authors, and how is this feedback received?
I'll take this one. We haven't provided the feedback. I think that'll be our next step as we move through the updates of CPGs. But I know we also have the GLIA process that we do take, and Jacob, you can speak
Yeah.
to that. We have
Yeah.
some of our team on the region side working with the CPGs to sort of give that guidance of, okay, this is computable, this is not. If we make this small tweak, if we're comfortable with that, we can make it more digitized or up on that grading scale as a more digitized key action statement. But Jacob, take it away.
Yeah, the GLIA, which is the guideline implementability, that's another word, appraisal. It's a tool that was developed by the one of the developers of the Otolaryngology Clinical Practice Guideline Manual that looks at how implementable the guideline is. So for at each one stage of the guideline development process or update, the key staff completes this instrument, and then they hold a meeting with internally, and then meet externally with the members to see if the key action statements are can be realistically incorporated, implemented into practice, whether there needs to be a revision.
Thank you. All right. We've got a handful of questions that are kind of along the same lines, so I'll summarize and a question that I had myself. What kind of personnel or expertise did you add to your guideline development team to implement this? So really, I think we're asking what type of staff is needed to do this work. I think as you noted at the start that implementation and guideline development, I mean, there's essentially separate sciences in essence. So did you kind of have this built in-house already, or how did you go about constructing that team? And along those lines as well, are there software products or other tools that you would recommend using to do this work?
So I can take this one. We did not add any staff members to do this work. So we have 9 folks in research and quality. So the 3 of us here. Then there are a data scientist, a data analyst, a person in charge of our core grants program, a person in charge of our CPGs who also tag teams with 2 of the other folks on CPGs and expert consensus statements, which is kind of a CPG light. That's what we call it here. And then 2 other senior managers that work on region, one who I would really label as a health informaticist, nursing background, and the other also healthcare background and operations background. So we've been lucky. Sometimes when you're in a smaller society, it actually works to your advantage because we don't have very cookie cutter. We're not just in our little area, like we're helping and we're stretching into other areas. And this team really likes to take advantage of things that we can talk amongst ourselves and say, like, how could we do this? Like the digitizing thing was something that was kind of plopped on their plates, and they came together to figure that out. So I do think we happen to have it, but I do think you need folks that can run data, know statistics, know methodology, folks that know coding, CMS. It's like a very mixed bag. And you also need implementers. So on a couple people's expertise background is that implementation piece. They also work on our plain language summaries for patients. So having that skill set. So we've been very lucky with that. The second part of that question, I think, was how necessary was region. I think again, because we're a small team, it was just like, how do we test it? In the past, I've been in otolaryngology for 25 years, which is why I can say the word, but I was at the academy a long time ago, and then I was in academic medicine at Duke for a long time. And what we used to, working with the academy, and what we used to do is take the guideline and we ran it through an actual study with a practice-based research network and would publish on, you know, what's actually happening in practice. When I came back to the academy a couple of years ago, it was like, wow, we had this awesome, huge, mega database that we don't even need to run a study in a network. We can just use the data that we have to track and monitor these guidelines. So it's just, I guess, serendipity. I'm not sure if I answered the question. I guess we were kind of lucky because we have the team members and they're all willing to kind of look into these things, but that's the skill sets. And yeah, I think Regent was absolutely a huge leg up in us being able to move this forward quickly for the feasibility study. The rest of it's not going to go quickly, but we're patient.
Very few things do move quickly in our field, I think. So let's see. Beyond member feedback, what other initial signals have you gathered to indicate whether digitizing guidelines is generally feasible beyond this pilot?
I think it's absolutely feasible. It's just, it's that slow walking process, and maybe part of this was answered already. We're going to do baby steps, implementing and socializing with our very established process and build that in. But it's going to start becoming part of every new guideline panel, that we at least have somebody at the table that is representing this digitizing perspective.
And do you think that, is there a business case to support this work? Can revenue be generated from digitized guidelines?
Well, that's an interesting question. I don't know if revenue, I think maybe value can be generated. I think it helps with payment. It helps with working with payers and services that are covered to show that there is quality by putting in these processes. Revenue wise, it does showcase that we have a quality improvement mechanism. I know that, you know, we are working with our board, who they are interested in using participation in this type of a process as part of what used to be called, it's different for every board, but basically the maintenance of certification angle of that process. So I think we have a value proposition that we'd be happy to share with anybody that is interested. That's what we use with our board of directors. And our CEO to say why we need to, our CEO is on board from the beginning, but just why we should be moving this forward. So yeah, it's more of a value proposition than it just being pure revenue.
Mm-hmm. So here's a question. Your guidelines are typically updated about every 5 years, and this guideline was published in 2020. Moving forward, will your process combine updating and digitizing the guidelines in tandem? And how does this align with the 18-month timeframe for guideline updates? And I'll tag on to that. I was curious in terms of, you know, I think that there's maybe some parallels with living clinical guidelines and the kind of iterative nature of it. And have you talked about that? You know, how kind of these concepts in this work might intersect in terms of challenges and opportunities there.
Yeah, I think that that's the piece that we touched very briefly upon, and a lot of you have been in CMS type of presentations about open evidence. We are a test case with them, meaning that we're working through a process for, if we have a guideline already published, how can we use open evidence and AI modeling to trigger telling us once a guideline is published when there is new evidence that we need to be alerted to that would be contrary to a statement. So we're very early on. but that's what we're working on to tighten. That would be the first thing that we would like to make strides in, because we're not taking out the human feedback loop, but we're being told through AI, like being triggered to look at something again, and maybe have the process not be to wait 5 years when it gets out of the queue, we have a panel again. It's like maybe we keep the panel kind of active the whole time, and then our staff member monitors, like there's something new that we have to alert the panel to. And living guideline means that it will be updated as the new evidence comes out, that there's an addendum or something that says key action statement 5 has new evidence associated with it. The panel met, and this is what was determined. So that's that process that we're trying to tighten. In terms of completely new guidelines, we haven't figured that out yet, but we will have this as part of the process so that they are computable, or have a computable guide, like compendium.
Oh. So kind of going back to the maybe the value proposition discussion, do you plan to do a comparison of implementing the computable version, against the traditional format?
Well, I don't think it's different. I mean, it's the traditional format will, I think, for the near term anyway, remain. The computable version is not different. It's just a way to assess what the traditional version has published. So they're not different versions. It's just to say, if you want to, I mean, we could, I guess, qualitatively do some sort of focus group to say, like, if the computable version doesn't exactly get at the guideline, and like determine if there are ways that we need to improve the computable version. Maybe that's the question. We could do that, but that is just coming to my brain right now, and I don't know that I can actually think too much further. But yeah, there might be a disconnect sometimes between what the intent of the written word is with the computable version, and that might be something that we need to look at.
Yeah, that's an interesting point. Because I wonder what your thoughts are on how many, how we currently develop clinical recommendations and write them, how many are well suited to translating into this more algorithmic kind of format. And how are you accounting for and considering, things like the strength of the recommendation and the certainty of evidence? How is that getting kind of translated into the computable guideline?
Right now, we're not worried about the strength of the recommendation. We're worried about we have been doing it based on, is it computable? I think both are important, because if it's computable and it's an option for example, in our guidelines, like it's strong recommendation, option, against, recommendation. If it's an option, I still want to know, like we still want to know about it, because if it's not being followed or it is being followed, and then there is new evidence, both those things help us understand, and our panels of experts understand what's actually going on in practice related to that option key action statement that they might want to revisit in terms of the strength of recommendation for or against. So if it can be tracked, we're going to track it, and then we're going to put it back in the hands of our experts to tell us how to address it.
Yeah, and I think from an implementation standpoint, from my side, we would want to make that flag abundantly clear, like this is the strong, this is option. That would be a part of our dashboard, our interactive CPG dashboard.
Yeah, and some of those, so that's a great point, Jocelyn. Some of those things we might keep some things, there might only be some things that end up on the dashboard, like based on evidence grade, and other things that we're keeping internally to help us with the constant living guideline and improvement.
Yep.
I see we have a hand up. So I guess I just want to check in on clinical decision support work group. I don't know if you had something kind of related to.
Yeah, sorry. This is Bryn. I'm the co-chair of the clinical decision support work group, and so that's why I always show up in meetings like that. Zoom just doesn't let me change my name. I was just going to suggest that there's active and ongoing discussion about how best to support clinicians in providing feedback about the recommendations that they're receiving. We've been having a whole bunch of discussions about different mechanisms that could be used. And one of the things that we're looking at adding to CDS hook specification in particular is a kind of proposed set of kind of feedback rule codes, reasons, that is based on the work that was done by the CDSIC group at ARC. They built an entire override taxonomy. And I was just going to add that I think that's a really important aspect of getting operationalization, that be considered. How do you let the clinicians provide the feedback about what they're seeing? Super important aspect of closing that loop.
We just say thank you because that's really helpful for us to kind of operationalize our next steps on that piece.
Yeah, and that will be part of what we are considering in this upcoming ballot of CDS hooks, if you really want to get into the meat of it. So we'll be discussing that more on upcoming decision support calls as well.
Great, thank you for that. We have more questions coming in, which is great. And I am going to drop into the chat a survey for evaluation of this webinar as we have more questions to get through, which is great. We'll keep the discussion going, but I wanted to put that out there for folks. If you're able to complete that for us, we really would value your feedback. Okay, so are you interested in digitizing the evidence or the summary of findings behind key recommendations so that they could be presented for decision support? So I guess including the potential for individualized decision support as, such as the patient's rating the relative importance of outcomes for the patient. So I guess more interaction with the evidence underlying the recommendations there.
Yeah, I think that's a great idea that we're definitely writing down. I think we're so far from that at this point, but that would be, again, the end goal. I mean, it would be great for it to be part of like shared decision making to have this type of information available, but yeah, we're pretty far away from that.
Mm-hmm.
Okay. Some more questions, I guess, about the role of the registry. So how integral was the registry data and looping to this implementation process and progress tracking? What advice do you have for specialties that do not have access to a registry or registry data? So I think we touched a little bit on the first part, but so what would you specifically advise for specialty societies that don't have access to it?
I don't know how to answer that. We basically put this together based on what we had in our toolkit. So I don't know. I mean, the way that we used to do it is do actual, small multi-practice studies collecting data that has a cost associated with it. If you're collecting elements to assess these types of things, this was just available to us in our toolkit, but
yeah, I don't know if it'd be worth collaboration with some of a willing health system or a couple practices to establish sort of a smaller cohort. But yeah, we were lucky in that regard that we did have a lot of data to play around with. But I think just starting small and identifying the data elements that would be needed to digitize, and then seeing if there's any collaborators out there.
Is there other infrastructure involved to support the computability? So, for example, software or platform to enter or pull information for the digitizing process? And is the cost to this kind of infrastructure reasonable?
Yeah, I mean, I don't think we're just using the tools that we have at hand, which is being able to pull it from our registry and then analyze it that way. I think that, and by the way, if we haven't said it, we would like to collaborate with anybody that's doing this type of work. I think part of the reason we are even where we are is because we were able to work with Maria Michaels and Bryn and those that actually just gave us like, we had multiple calls just saying like, we don't know what we're doing. Like, we would do baby steps and show them what we did and they would help us. So I don't want to offer out, but I think they're a resource to all of us. And as far as I know, I didn't get a bill for it, but they were very willing to help us figure out something that seemed really insurmountable to us. I have to be honest, it was very confusing. To help bring it down to like baby steps so that we could get this feasibility project off the ground and then get this sense of, oh, we can do this, and we still have a lot of like knowledge to gain and work to do, but we can do it. And it didn't have an additional cost internally of adding staff or getting software or resources. It just, we needed the guidance.
Along those lines, I received some information from Brian Alper in the chat. So I'll put his message back out to the full group. I don't think it went to everyone. So that's there. All right. And I'm hearing that. And I'll put another link from Bryn with the Clinical Decision Support Work Group in the chat. Thank you for that. Okay. So given the caution, this is getting to your kind of comments about, or your thoughts about using AI in this process. So given the caution surrounding the use of AI in guideline development, how do you plan to incorporate it into this process? What kind of safeguards are in place or are you thinking about to address issues such as phantom studies and inaccurate references?
Well, so open evidence, if you don't know about it, it is a somewhat closed AI system. You have to have an NPI, a national provider indicator, to access the system because they want the users of the system to have clinical knowledge. And so we are working with them. They have relationships with, and if you just Google them and go on their website, they have relationships with a bunch of different big journals like NEJM and JAMA. And what is different about them is when you do the AI question. So if you ask something, it's accessing the full text of the journal article for the response. So it's already giving you a higher level of response because it's not just accessing like an abstract. So that eliminates one layer of noise. Then in terms of how we access them, we are very tight with how we use AI, so there's always a human element. So if we can figure out a way to engage them, which is what we're doing, it would be they provide feedback from AI, but then it's humans and clinicians that review that. It's just kind of reducing the amount of legwork that our panel members and experts and our staff have to do. It kind of puts it in a little basket for us to look at. But with human interaction, we might say not good enough. We're not using this. So it's very tight. I mean, we're using the same guidelines as our journal uses, and yeah, so we're very well aware of that.
All right, so it's looking like we've gotten through our audience questions, which was great. Those were a ton of questions. I think you can see the interest from everyone. And I think this has been so helpful to kind of really understand how to operationalize these concepts. It's been really great to kind of walk through an example like this. I guess maybe one place where we could kind of wrap things, if there are no further questions, is kind of coming back to, you know, there's a lot of questions about how do we actually do this. So if you were to give advice to a guideline developer group that is just getting started in this, like what are kind of the first initial steps that we need to think about, that we need to take? Where do you start, I guess?
I think to not be scared.
Yep.
Because it's easy to be scared and say like, oh, it's too hard, we can't do it. If it doesn't work, there's no harm, no foul. You can slow walk it. If it takes months, you're still making progress. And then if you take advantage of the resources and I think for us, it was critical to have our entire team involved, because it's probably similar at other organizations. Everyone on the team has a little bit different knowledge base, and the same message triggers them in a different way, that they come out and say like, oh, I heard what that person on CPG on Fire said, like we could do that. And so just letting people be creative, let your team be creative, don't be afraid to wade into it. I mean, maybe I wouldn't suggest submitting an abstract to annual meeting before you do the feasibility study and then figuring it all out in the next 9 months, because that's a little scary. But I think just not being scared about wading into new waters, because I think this is where we're going. And CMSS has a great series on AI, and clinical practice guidelines was one of the focus topics, and it's available now on their website to listen to. It was excellent. I would recommend listening to that, because that gave us a lot of great ideas. I think it was about a month ago, but now it's available to listen to. So I would recommend that.
Jacob, Jocelyn, any insights, thoughts from your end?
Yeah, I think our team is just built on we always say we're doers, so just like you just have to jump in and go for it. So I think that's where we're really fortunate to have a group of people that are not afraid to just go do it, and not afraid to fail. If it doesn't work out perfectly, we'll refine our process and improve it the next time.
Yeah, I fully agree with my colleagues, and especially the harmonization of data and guidelines to enhance evidence-based practice.
And there's a question if the link to was it CMS or CMSS that you were referring? I think it was CMSS.
CMSS.
Yeah, if the link can be shared to the group for that, if you're able to. You know what we can do is I can work with Jen. We can pull that link and we can share it along with the other resources that were shared in the chat when we send out a follow-up through Jen with the survey. So we'll work on compiling those resources to get it out to the attendees.
Put it real quick.
Oh,
just the general link.
Okay, great. Maria, go ahead.
Yeah, I was just going to mention, if it's of interest, especially to the various guideline development groups in societies or otherwise. I know we're always thinking about tooling that can help with things like making guideline content computable. And there are, Bryn sort of mentioned this, that there are efforts underway. If we get to various points where it would be helpful to have input from folks like you guys, those that develop guidelines or support guideline development, would there be interest in me sharing it, say, maybe through the GIN North America steering group to the list, like GIN Connect list? I guess I'm seeing a couple nods on the screen, but is that of interest to anybody? I'm happy to do that whenever there's an opportunity to get your input and understand what would be most helpful.
Yeah, sure, Maria. That sounds like a great follow-up for this.
All right then.
All right, and then thank you, Chris. She was able to drop that link in the chat. And like I said, we'll try to get kind of these resources organized and try to get them out with this survey that'll get circulated. So with that, I think we are, I'm seeing no more questions. And so I just want everyone to kind of join me in some virtual silent applause for our speakers today. And also thank you to the audience for, for your great questions, your great contributions. This has been a really useful, I think, webinar for me personally. So I really appreciate all the time of everyone. So with that, have a great rest of your Wednesday, all.
Thank you.
Thank you.
Thank you.
Thank you.